Welcome, everyone. I hope everyone is able to slowly get in and enter the webinar. Please identify yourself to my colleagues. I am thrilled that you've made time to be part of this conversation. My name is Hina Shaikh. I co-direct the Globally Oriented Center for Social Wellbeing and Development, or CSWD, located in the Department of Prevention and Community Health at Milken Institute School of Public Health. Before we get started, please note that for security purposes, we will be locking the room at 12:10. And so I ask that you please identify yourself to my colleagues to enter the webinar. Also, I've asked one of my colleagues to place the center's Twitter handle and website URL in the chat field so that you all have them. We did launch our new website this past June, and we'd love for you to have a look when you have a chance. First, very importantly, I hope that you all are keeping well and that your families are safe and well despite all of the challenges around us. Second, I'm so pleased to see that we have a tremendous turnout. It appears to be an international turnout, which is very exciting to see, and something that is not necessarily possible in ordinary circumstances. To have people join from outside of the US. And it appears that thanks to technology, this appears to be a small upside of doing our work during this pandemic. I am very excited to moderate our webinar today to share some of the exciting research that our center's faculty and staff, including myself, have conducted in different parts of the world. Although CSWD was founded in 2012, some of you may not know about our mission and our work, so we decided to convene this webinar. I believe that our multi-level social ecological perspective on health and social problems is so timely with the different dimensions of the pandemic that we are living through. It has been an intensely challenging year for all of us in one way or another. And as we all know, the pandemic continues to be unrelenting and deadly. We see this particularly in the United States due to issues concerning equal justice and varying economic and health impacts of the virus based on race and ethnicity. Underlying health disparities have been brought to the forefront by COVID-19. And the situation has been hard on everyone in different ways. And for me personally, it has affirmed the critical importance of public health and the mission of our center. So with that, I want to briefly describe the outline for today's program, which will feature Dr. Mark Edberg, professor and founding director of the Center for Social Wellbeing and Development, and Dr. Bart Bingenheimer, associate professor at Milken Institute School of Public Health and the affiliated center staff. I've asked each of them to present briefly, and then we will open it up for Q&A for the remaining time. So please, at any point during this webinar, during this hour, please feel free to enter your questions and your comments, and we're going to try to get to as many of them as possible. Before we get to their presentations, I am very excited and honored to have Dr. Deanna Kerrigan provide a brief welcome and opening remarks. Dr. Kerrigan is the new chair in the Department of Prevention and Community Health at Milken Institute School of Public Health, where our Center for Social Wellbeing and Development is situated. So with that, over to you, Dr. Kerrigan, and thank you so much.
Thank you so much, Hina. Really appreciate it. I want to welcome everyone again, and I want to extend my thanks to Mark Edberg, to Hina Shaikh, and Bart Bingenheimer, as well as all of the leadership and logistical team of the Center for Social Wellbeing and Development. It's really a pleasure and a privilege for me to have this webinar be one of the first activities that I do opening remarks for in my new role as chair of the Department of Prevention and Community Health. So thank you all for inviting me today. And as Hina mentioned, one of the important goals of today's session is to highlight the important work of the center to the fields of both global health and development, as well as the social and behavioral sciences as it is applied to public health, and to stimulate a discussion around our around both the contribution of the center, but also our collective future engagement with the center and its potential contributions moving forward. The concept of social well-being, as Hina just mentioned, is particularly salient in this historic moment in time. Because to promote social well-being is to recognize the tremendous amount of social suffering that is occurring all around us, domestically and internationally, related to multiple forms of intersecting social and economic inequality, stigma, discrimination, and violence. The framing of social well-being is particularly important at this moment because it recognizes and gives visibility to a deep philosophical truth and a practical matter, which is that our health and well-being is interconnected as human beings, and that interconnectedness is set within a social and physical ecology. The center has used the socioecological framework in a nuanced manner to understand and address the vulnerabilities and needs of children, adolescents, and families across settings, including South Africa, Ghana, and Belize, which you'll hear more about today. I think many of you know that the socioecological framework is very common in public health. But what I really want to emphasize to you all is the manner, the thoughtfulness, and the sophistication with which this framework is utilized by the Center for Social Wellbeing and Development. Rather than simply identifying and documenting specific levels of influence on a given health outcome, the work of the center has worked to establish close partnerships with communities to give voice to the most salient aspects of their family and community dynamics, to illuminate the nuance of these experiences, and to give voice to these realities by working to challenge sociostructural constraints to health. I truly look forward to the presentations and discussion today and welcome you all to join the conversation not only today, but to engage with the work of the center and PCH as a department in the days to come as we work together to continue to transform social suffering into social well-being across underserved and marginalized communities and geographies. And I want to extend a special thanks and welcome to our colleagues at UNICEF and recognize and appreciate their support for this very important work. Thank you. And I'll turn it back to you, Hina.
Thank you, Deanna. Thank you so much, Dr. Kerrigan. It's my honor to present our first panelist, my friend and my colleague, Dr. Mark Edberg, whom I've worked closely with on multiple CSWD projects over the past years. Dr. Edberg is a professor in the Department of Prevention and Community Health with secondary appointments in the Department of Anthropology and the Elliott School of International Affairs, and founding director of CSWD. He is an applied and academic anthropologist with over 25 years of experience in social research, interventions, evaluations, strategic planning for agencies, and communication, primarily in public health in both the domestic and global contexts. Over to you, Dr. Edberg.
Thank you. Thank you very much. Michelle, do you want to cue up the slides? Okay, great. Okay, next slide. All right, thank you again so much for being here. And just wait 1 second while I do something with the, there we go, get the speaker thing out of the way there. All right, so just briefly, and Hina already mentioned this to some degree, the Center for Social Wellbeing and Development is a chartered center. We were chartered in 2012, and you know, thank you again to our UNICEF colleagues, because we actually chartered as a center when doing some work with UNICEF Belize, and we had a Center of Knowledge agreement with Belize in 2012, and that was the sort of the genesis of the center. So our, you know, our mission again is to use that kind of social ecological approach to support positive health and social outcomes to reduce vulnerability in global and transnational settings. And I'll explain what I mean by that in a minute. Next slide. So one of the advantages, or one of the great benefits that we enjoy, is that we are based at a research university. So we can draw in faculty from many different disciplines and across schools to work on particular projects as needed. And our work, as Dr. Kerrigan said, supports the understanding and use of a social ecological approach. And I know that term is used and maybe overused in some ways, and hopefully you'll get a better sense for how we actually hone down and apply that. But basically what that means is that we are looking at a given public health issue in terms of how it is embedded in a broader context, not as an isolated phenomenon. So hopefully the interventions and other approaches that we bring to that are allow us to not treat something with a Band-Aid kind of solution. So we develop practical tools for using the approach with children, adolescents, and families in vulnerable populations. And we try to identify elements in the social ecology that contribute to a particular problem and direct interventions at those. Next slide. So here's my beautiful artwork here, just a little graphic of an ecological model, in a sense, with individuals nested within that broader context. Next. We have some practice areas. We have focused on youth and youth development, especially youth at risk. We done a lot of work on prevention of violence, chronic disease prevention across the life cycle, and working with migrants, immigrants, and refugees, and looking at transnational social determinants of health. Next. And I won't go into this in detail, but we've had a number of projects, including a long-term agreement with UNICEF, a range of projects with UNICEF in South Africa, in Indonesia, in Ghana, in Jamaica, and in Belize. And we've also done work on looking at transnational health determinants for Central American immigrants. Next. So I'm just going to talk briefly, and I'm going to really skim through these, so my apologies in advance for that. Some two sample projects, and hopefully this will give you a sense for how we work in these settings. So the first project was the development of a communication strategy for preventing violence against children in South Africa, and this was for UNICEF South Africa. What we were looking at was the prevalence of multiple types of violence in South Africa, high prevalence. And when we were thinking about violence against children, it came in many forms. So we were talking about infanticide, child abuse and neglect, physical discipline, sexual abuse, family violence, involvement of youth in gangs, etc. So to address, so maybe go back up one more time. Sorry about that. Okay, yeah, so anyway, the other thing was that the evidence base for effective interventions was limited, and we had a very short time period to do this project. Next slide. So what we did, we used that social ecological approach, tried to identify levels of influence on violence against children and pathways of influence. We worked with a number of partners. We conducted key informant interviews with a range of parties, people addressing violence against children, ministries, UNICEF, broadcast media, universities, and then we also conducted focus groups with parents, youth, teachers, and service practitioners, then held stakeholder meetings to sort of review the draft strategy and get final comments. Next. So a few things that came out of this was clearly that violence occurs in multiple settings, in home, school, community, and television, and online. And this was a very important point, is that violence against children, along with other violence, really drew from a history of apartheid and oppression, and that we needed to address that in our communications. And it also drew from some of the socioeconomic consequences of apartheid and from some particular traditions, particularly related to child discipline. We also found out that there was a network of communications efforts and organizations at many levels that had been mobilized previously for HIV/AIDS and violence against women, and we could draw on that. Next. So we had a 4-phase strategy that addressed these various levels. So in phase 1, this is what we proposed. This is where we would introduce the broad themes, addressing the broader sort of normalization of violence, which was a really important issue, is that violence had become normalized. So we did that by, among other things, sort of connecting the reduction of violence to almost like a social movement, moving beyond apartheid. And then we introduced other themes with that. In the next phase, we moved to helping individuals understand, not only recognize violence against children, but learn about some ways in which they could do alternative ways of engaging with children. In that third phase, we engaged social resources to support that behavior change with social mobilization, peer groups, and in schools, et cetera. And then in phase 4, that was cast as an advocacy phase for sustainability to try and advocate for resources to continue that. Okay, next. And here is another lovely piece of art. I know this should go in a museum. It's a minimalist and an abstract art representation of that strategy as a whole. And you can see sort of the flow of how those different phases proceeded. Okay, next. All right, the next sample project, and again, I'll go through this quickly, is actually a cluster of 2 related projects. And these are 2 situation analyses we had done in Belize, one in 2011 and one that we recently completed in 2018. And if you don't know, a situation analysis, and I'll just use the term SITAN, is a key document for UNICEF. It is the basis for UNICEF negotiating 5-year plans with country governments. It's typically organized around the rights and development goals that UNICEF has to monitor. But for both of these SITANs, we proposed a broader social ecological framework where we would not just focus on narratives about the current rights and development data, but explanatory and contextual narratives that linked that data to sort of a causal multi-domain matrix of some kind. So in 2011, we organized that around what we proposed as domains of social well-being. And in 2018, we organized it similarly, but there were some other domains that UNICEF had requested. Next. So, and again, I'll go through these really quickly. In the Belize situation analysis, we had one domain for proximal immediate experience. So this is what people experienced across a number of domains. And then the second domain was domains that were related to the capacity that fed into whether or not, or what people experienced. Next. And then we had 2 domains under that, which were underlying factor domains that affected capacity. So inequity and poverty as these related to group and region, economic vulnerability, and underlying that, cultural factors, which are very important in Belize because the sort of regional and cultural landscape is connected to inequity and poverty in some ways. And then geography and governance. And so we link those together into the next graphic, which is our model for how we did the causal analysis. And you can see that the domains work up from the underlying domains up to the actual expression in terms of the domains of social well-being and how that played out in terms of achievement or not achievement of child rights. Okay, next. Very similarly, in the 2018 situation analysis, one of the things we needed to address was that there were a range of thematic areas that UNICEF had called on us to cover. And each one of those areas was a chapter in the situation, in the SITAN. All right, next. And in each chapter, I know this is a little crowded, we sort of played out that social ecological model. We had 3 levels. We had in each chapter a discussion of the experience of that particular rights area. And then at another level, we looked at causal mediators. And this was all kinds of elements of the enabling environment, supply, demand, quality of services, and other things. And then we also had a level 3, which focused on drivers of inequity related to that domain. So that was the look at underlying gender issues, poverty, geography, ethnicity, so on and so forth. And then we summed that up with a causal analysis. Next slide. This was our overall logic model, our ecological, social ecological model for doing that. And again, you can see the play from left to right of multiple factors at multiple levels. And if you go to the next slide, you see an example of what we did, actually the slide following, the next one. I know you can't read it, but this is just to give you an idea. So in each chapter, we finished the chapter with a version of that broader logic model specific to that domain and some key points in terms of what were the drivers of inequity, mediators, and outcomes. And we did 2 versions. One was continuing areas of need since the 2011 situation analysis. And then in the next slide, then we also wanted to acknowledge areas of improvement since the 2011. So we used that same model for that. So this was in every chapter. And then if you look at the next slide, you'll see in the slide following that, you'll see this is the kind of, at the very end, we tried to propose just an overall causal schematic for issues that impacted on the achievement of child rights and beliefs. And again, you can see that what we did here was we operationalized a social ecological model, and the recommendations were focused on addressing some of these causal pathways insofar as it was possible. Okay, hopefully I didn't exceed my time too much. Thank you again, and I will turn it over to Hina.
Thank you, Dr. Edberg. Our next presenter is Dr. Bart Bingenheimer, who Dr. Edberg and I have had the pleasure of working within the Department of Prevention and Community Health for a number of years. Dr. Bingenheimer is an associate professor at Milken Institute School of Public Health, whose research focuses on influences of social context on behaviors related to sexual and reproductive health. Over to you, Bart. Thank you.
Thanks so much, Hina. And I'm going to share my screen and my slides, hopefully here. Come on now. There we go. All right. Hopefully this is right. So yeah, so officially I'm Jeffrey, but everyone calls me Bart. And as Hina mentioned, I'm an associate professor in the same department as Dr. Edberg and several others who are on the call. And I'm going to talk a little bit more in depth about one project that the center did a few years ago called Social Norms and Behaviors Related to Child Survival in Ghana. So this was a project that we contracted with UNICEF Ghana. They were the initiator, and we applied for a contract. And aside from the GW School Public Health / Center for Social Well-Being and Development team, which included myself, Dr. Edberg, Hina Shaikh, and several others. We worked very closely on this project with a research partner in Ghana, particularly the Institute for Statistical, Social, and Economic Research, which is housed at the University of Ghana. And that part of our team was headed by Dr. Elizabeth Asante there. I think she's actually on the call today. So bonjour, Elizabeth. And so this is a project that we did a few years ago, back in 2016, 2017. So the objectives of this project, and in some ways this project actually, I should say, was a bit narrower than I think most of the projects that the center has undertaken, in that it was particularly focused on social norms. And that was part of what UNICEF Ghana was asking for, was, you know, how to incorporate messaging related to social norms into its communications for development related to several different behaviors related to child survival in Ghana. So in order to do that and give them that guidance, those recommendations, we wanted to determine the extent to which mothers' decisions to perform these behaviors, and I'll mention in a moment what those were, determine the extent to which those behaviors are influenced by perceived descriptive norms, also by perceived injunctive norms. We also wanted to identify who were the individuals and groups that people regard as their reference groups, the influential people in their lives in relation to these particular behaviors. And also a key part of sort of the social norms theory is that norms are often enforced by social consequences, informal social consequences. So we wanted to characterize both the positive and negative social consequences. So, you know, just as background, child mortality in Ghana has recently been estimated at 60 or perhaps 82, depending on which survey you look at, deaths per 1,000 live births among children under age 5 in Ghana. That represented a significant accomplishment from from 1990, was down by over 50%. But it was not down as far as Ghana's Millennium Development Goal, which was 42. Anyway, and one of the key realities in Ghana, as in many other countries in West Africa and throughout the region, actually, is within country variability. And so the highest rates of child mortality are in Ghana's northern region, where the estimates stood at 111 and 124 deaths per 1,000 live births. So almost twice the national average there. So UNICEF Ghana was interested in looking at social norms in relation to 6 behavior groups: maternal nutrition during pregnancy, facility delivery and skilled birth attendant use, postnatal health checks, breastfeeding initiation and maintenance, nutrition of children from 6 months to 24 months of age, and health care seeking for sick children. So those 6 behavior groups translated into 13 specific practices, which were thought to be particularly important for child survival and potentially the modifiable risk factors for child mortality. So these are the 13 specific behaviors, and many of them, as you'll see, are the sort of recommended behaviors that WHO recommends and that UNICEF Ghana and its partners in Ghana try to promote. Some of them, though, are what we call competing behaviors. That is, behaviors or practices that are competing with the recommended behaviors. So, for example, number 7 there, avoidance of colostrum, would be potentially competing with the immediate initiation of breastfeeding. And similarly, in 13, seeking non-Western care like traditional medicine for a sick child or some kind of a spiritual medicine, with potentially competing with healthcare seeking for a child with nutrition problems. So these are the behaviors we wanted to study. And, in general, what we wanted to answer is, what can UNICEF Ghana and its partners in that country do to improve the situation overall for child survival, and specifically in relation to those behavioral inputs on child survival. And of course, all those practices and child survival itself is influenced by a variety of factors at multiple levels. This is well known, but our charge was specifically to look at social norms and to what extent do social norms influence these practices, and how could we potentially leverage that in the design of communication for development campaigns to improve child survival there. So a little bit of sort of theoretical, I guess, background about social norms. Social norms have a variety of definitions in different fields. We drew primarily upon 2 sort of specific conceptual or theoretical orientations. One approach that comes from Christine Vicheri, and another that comes from formerly our own Rajiv Ramal, who's now left us and gone to Hopkins. But both of these theories talk about beliefs about what others do. And the idea is that when one believes that many people in one's community or one's social network, or people who are like one, when people, to the extent that people believe that many others practice a particular behavior, that can make them more likely to consider practicing it themselves. And conversely, when they think that there are behaviors that are rarely practiced by anyone in their reference group or their community, then they may be less likely to practice those same behaviors. So that's what's sometimes called perceived descriptive norms or empirical expectations. It's individual beliefs about what others, important others do. And then that's distinguished from what's sometimes called perceived injunctive norms, or in Vicheri's framework, normative expectations. So these are beliefs about what others think one should do. So do I believe that people in my network think I should deliver in a health facility, or do they think I should initiate breastfeeding immediately after birth, or do they think I should not do those things? So in any case, so the theory talks about those 2 types of norms, injunctive and descriptive, and they exist both sort of at the individual level in terms of individual perceptions, what people believe others do and what people believe others think, but they're also related to sort of a collective phenomenon, collective descriptive norms and collective injunctive norms. And in all of this, it's important to bear in mind who the reference groups are. So sometimes the reference group may be a geographically defined community, but in our increasingly networked world, it could be a community that you're connected to via internet on Twitter or Instagram, and people that may be halfway around the world from you. So and then the last part is the idea of social sanctions, that social norms in a way are informal rules. They're not generally like laws that are enforced by the police, but they're informal rules, and they're often accompanied by social sanctions that individual people in a community or a network enforce these norms in different ways, but through their interactions with each other. So we tried to sort of apply this theory to these particular practices in Ghana, and focusing on a few specific areas in Ghana, particularly regions, including Northern region and Volta region, where some of the practices of interest were, had particularly bad profile, like low levels of breastfeeding or low levels of facility birth, and also focusing on districts within those that were high poverty districts. So this map of Ghana shows the districts that we did our work in. And just so those of you who aren't familiar with Ghana, it's in the sort of lobe of West Africa, facing south into the Bight of Benin, the Atlantic Ocean. So along the bottom there, that's the Atlantic Ocean, with the capital Accra, about 3/4 of the way from the lower left to the upper right. And then it goes up into the drier, almost Sahelian parts of West Africa, where it bumps into, at the north, Burkina Faso, and then on the left there's Cote d'Ivoire, and on the right or to the east there's Togo. Anyway, so what we actually did, we did two sort of phases of data collection, and these were headed by our team at the Institute for Statistical, Social, and Economic Research at the University of Ghana. We did a qualitative phase that consisted of 24 key informant interviews and 27 focus group discussions, stratified by sex and age, and then also a quantitative phase where we did surveys, and that had a sample size of 600. So in the qualitative phase, we used vignettes, stories about people who we were facing decisions about where to give birth or when to stop breastfeeding or so on. And through how people reacted, participants reacted to those vignettes, we sought to uncover descriptive and injunctive norms and find out about the reference groups. In the survey questionnaire, we asked, so we measured behavioral intentions to do each of the behaviors in the future, and analytically we used that as an outcome because we wanted to see how perceived descriptive norms, perceived injunctive norms, and other factors were associated, to what extent those are predictive of what people intended to do behavior-wise in the future. So this just gives some examples of the wording of questionnaire items that we used in the survey, in this case about the initiation of breastfeeding, to measure behavioral intentions to breastfeed, perceived descriptive norms and perceived injunctive norms in relation to breastfeeding. And we also asked about the perceived benefits and harms of breastfeeding, and the perceived ease or difficulty of breastfeeding. And we did the same type of thing for the 12 other behaviors that were on the list I presented before. So anyway, so let me go ahead to the results. So overall, when we wanted to, kind of make recommendations to UNICEF Ghana, we wanted to classify sort of each focal independent variable, including perceived descriptive and injunctive norms, as either very promising, somewhat promising, or not promising, as a potential avenue for communication for development strategies. And so in order to be very promising, an independent variable had to exhibit substantial room for improvement and a consistent positive association with intentions to practice the behavior. So what were the findings? Well, we found that it's hard to summarize in just a few minutes, but overall we found that different practices had different drivers and therefore called for different strategies. Oftentimes the competing practices or competing behaviors seem to offer more avenues for intervention than the recommended practices or recommended behaviors. And this slide summarizes across the 13 behaviors the extent to which perceived descriptive norms, perceived injunctive norms, et cetera, were promising, somewhat promising, or not at all promising as avenues for intervention. So the green means, again, promising. So you can see there's some heterogeneity here with respect to, some behaviors being more amenable to intervention in different ways. So in general, we found that people recognize the benefits of the recommended practices, although there was one exception, which was two exceptions, antenatal care during the first trimester of pregnancy and exclusive breastfeeding for 6 months, which people thought weren't completely necessary, although not bad. People often saw competing practices as being beneficial as well. And one of the sort of socio-ecological sort of insights is the relationship between sort of practical barriers, which would be sort of both physical and institutional, and the potential formation at a collective level of descriptive or injunctive norms. So for example, if it's very difficult to get to a health facility, people may think that, it's a good thing, but they may think that people don't often do it because they realize how difficult it is to get there. So anyway, there are a lot of other findings, but I'm going to skip over them because I think I'm basically out of time. But basically, this sort of summarizes that some of the things where descriptive norms were promising avenues for intervention, things where injunctive norms were promising avenues for interventions, and things where neither of those was particularly promising. So with that, I will exit my slides and stop sharing and hand it back to Hina. Thank you, Hina.
Thank you, Bart, so much. Well, just staying on the Ghana project, I'm monitoring the chat field, and I'm seeing a lot of great questions coming in. One I'd like to direct to you, Bart, to respond to. One person has written in, I'm assuming observing behaviors can be frustrating because you cannot implement any interventions at that particular stage. What was one of the most challenging aspects of the Ghana project? So if you could kindly respond.
Let's see, what was the most challenging? I think, honestly, the most challenging aspect for me was trying to deal with sort of the breadth-depth trade-off. So, as I mentioned, there were 13 different practices that UNICEF Ghana was interested in. And in relation to each of those 13 practices, we had perceived descriptive norms, perceived injunctive norms, perceived benefits and harms, perceived ease and difficulty, all this kind of stuff. So if you multiply, 5 constructs by 13 behaviors, you need, at least, whatever that adds up to, 75, I think, questionnaire items. And that's before we even get to, basic demographics and so on. So it was, as an investigator, I would often, want to be able to delve more deeply into a particular behavior or practice, or a smaller number of closely related behaviors or practices. But I think that's, hard when you're, sitting in the UNICEF Ghana office in Accra, and you realize that child mortality has all of these behavioral determinants. And so, for me, that was probably one of the hardest things, was how to sort of balance that breadth-depth trade-off.
Absolutely. Thank you. Now, Mark, I'd like to turn this question over to you. A participant has asked, we often hear about social norms being negative, but can they also be health promoting? And what are some ways that the center, can help facilitate that?
You're on mute, Mark.
I am. So excellent question. And there could be about 3 webinars just about that question in itself. So you know, if we're thinking about norms as these kinds of practices that people do, let me just first say, and I'll have to say this in just a sentence. And again, this is something that could go on, but you know, norms and investigating norms is complex in part because, as you know, from our own perspective, norms are embedded in broader things. So what people do may be expressions of something something broader, like gender hierarchies or power hierarchies, or what you find as a norm may be kind of a signifier in the sense that if I do this, that means I'm a good person. Okay, and people who don't do this are not good people. So there may be things like that are you know, that are involved in looking at norms. So you can, it's like a maximum here is that you cannot approach looking at norms one-dimensionally. You have to really be careful about making assumptions. Just because you see a practice happening, you need to look at what's underlying that before you understand, you know, what makes sense in terms of changing that. But so that said, clearly in doing any kind of investigation of norms, there's, you know, a lot of what people do is health promoting, you know, clearly. I mean, things that people might do in terms of diet and other things. I mean, if you think, for example, and this is just popping in my head right now because I was talking about it with someone, Native Hawaiian diet practices, for example. Those were sort of, you know, normative practices at one point, and many projects are trying to revive those because those practices were health promoting in terms of eating lots of fish, you know, growing and eating taro, and the social activities that were involved in collectively growing and eating taro, which was a social benefit too. You could find all kinds of norms that exist that are, if you can identify those are great. And they're great for an additional reason, and that is because you will be, if you're working collaboratively to try and develop an intervention, it means you are, you're not coming from the outside to impose norms. You're coming from the inside, and you're working with a group of people and saying, you know, tell me what you do that is, you know, and we can take a look at what the outcomes are of some of those things that you do. And some of them may be health promoting, and likely are. I mean, people have been around for a long time. So there's a lot of things that people do that are health promoting. So hopefully that answers your question.
Thank you. Okay. Thank you, Mark. And Bart, I believe you wanted to add something, so please go for it.
Yeah, just to kind of add to what Mark said, I think in our study in Ghana, we found that, you know, the perceived descriptive and perceived injunctive norms more often than not were sort of promoting of the you know, the behaviors and the practices that UNICEF Ghana would want to be recommending to people. And to address Mark's idea of embeddedness, often I think they were, so when it comes to sort of social consequences, often the biggest sort of social consequence was respect or lack of respect from one's neighbors, one's family, one's community. And then the norms and the practices were very much embedded in sort of broader, what you might call like meta norms about, number one, good motherhood. So what does it mean to be a good mother? A good mother cares for her children and loves her children. And then that manifests as taking care of her children by, you know, following the recommended practices. There are other sort of meta norms that were involved as well that I think were important, such as the meta norm of listening to experts and respect for authority and expertise. So, you know, if the doctors, if the government, if those, you know, so anyway, so by doing those things, people can show their respectability, they can show their good motherhood and earn the respect of their neighbors and family members, and conversely, the opposite.
Yeah.
Thank you. Thank you so much. Mark, another question for you that a participant has wanted to ask, directed to you. What would you suggest in terms of methodologies for conducting the more ethnographic side of the center's research during a pandemic, or during the pandemic that we're currently in?
Yes, that is a really good question, and it's a difficult question. And I'll tell you, one of the things, for example, you know, we recently, and actually I think the participant, Dr. Benavides, participated in one of our projects, which was, conducting interviews with Central American migrants, which in itself was difficult to do. It was difficult to recruit in this current climate pre-pandemic. But thinking about some of the partners that we have in the community in our current discussions and applications for various kinds of project fundings, we've tried to work out methodologies like this, and it includes using tablets and doing Zoom interviews via tablets. There are other, basically we have tried to work with, as best we can, using mobile technologies and using some kind of, whether it's Zoom or other platform, to conduct the interviews. So if you do ethnographic work, you know that this is very, very restricted, because you cannot see, and you can't really see anything else that's going on. So, so in that sense, I mean, that is one approach that we have used, and with some of our partners in the Latino community have already used some of those platforms with success. So we have, community outreach workers who are already members of the community, and they get trained in using, whether it's through phones or iPads, using those platforms to conduct these, Zoom interviews and things like that. So it's not as fully ethnographic as one would want, but you could probably supplement that with, other kinds of, with permission, of course, video documentation of a setting or a scene, and weave those together. And at this moment, ojalá that this moment passes, we could go back to the other ones. But those are a few, and I hope that partially answers your question.
Thank you so much. Bart, I think the next one I will direct to you, although Mark, please chime in. But Bart, for you to respond to first, a participant has asked, do normative expectations and perceived inductive norms usually coexist? And also, part two, which one is more prominent?
It's a good question. I think they generally do tend to be positively correlate with each other, that people tend to think that most people do the same things that they think that other people think that they should do. But there are exceptions, and this is one of the things that I think came up in our research is that oftentimes it's sort of the practical, either physical or institutional barriers that come between the injunctive, like what people think others should do, and the descriptive, what they think people do. And so, perhaps one way of sometimes bringing those into line is not through, C4D communication strategies aimed at influencing people's perceptions of norms, but rather by actually removing the physical or institutional barriers for people to do the things that they already think they should do and even want to do. So I don't know if that fully answers the question, but I'll hand it off to Mark.
And just to comment on it, that's a great answer. And, Bart is a norm expert. But one thing to think about when you have those, intervening physical or other kinds of access barriers is that it's sort of like eddies in a current. They themselves often will create norms. And this is one of the things that I've run across in looking at sort of, and I'll use the word subcultures that grow out of social marginalization, is that when people are denied access, over time, the ability to cope with something without, let's say, going to the doctor or doing these things that otherwise might be, there might be positive norms for, those things become normative in themselves. And they may then even be related to people's understanding of, well, we can't access these services anyway, so our lifespan is probably going to be shorter, and that then is going to influence the creation of and growth of norms that may support, things that would otherwise be viewed as, riskier health behaviors or strategies for coping with a health condition that aren't optimal. So it's a dynamic thing. Working with norms is very complicated, and I will just, not to be self-promoting, but I will promote an article that Dr. Lori Krieger, who I believe is attending, and myself recently published in Social Science and Medicine, Population Health, which was an attempt to take a look at some of these broader ways in which norms, so play out and are embedded. So if you're interested, that's one of many sources, to look at in that.
Thank you, Mark. And just watching the clock, I will ask one more question and then ask you for some brief closing remarks. So one participant has asked, as a student at Milken, I'm interested in getting involved with the center. Are there any opportunities for students?
The question of questions. Yes, probably, and I qualify it by saying that right now, and this is an evolving process, the center is funded by project funds. So that is, when we get a project, then we have funds to pay for research assistants and other things like that that are involved in the project. And when that project is done, we don't at this point have operating expenses. So, so we rely on other sources of funding for people that are involved in the center, or as interns and doing internships and things like that. Yes, absolutely. We make as much use as we can of anyone who's interested in that respect. And we are in an ongoing process of looking for not just the kind of shorter term projects that we've done with UNICEF, but longer term efforts that can sustain that kind of operational funds and provide those kinds of opportunities. But the answer is yes, with some qualifications. Let me know, let Hina know, and we can talk to you further about that. But we welcome your interest, absolutely.
Thank you so much. Well, we have 4 minutes left before the 1 o'clock hour. So Mark, just any parting thoughts for our audience? And then I will say some closing remarks as well.
Okay, great. First of all, thank you all for your interest in participating. This is great. It really is. Thank you to Dr. Bingenheimer, Dr. Kerrigan, co-director Hina Shaikh, together with Michelle Yang and Dominique Tuya for working to make this webinar happen, and a special thanks to Rosie Delk, who handles our social media and does just an unbelievable job. So we have a lot of, had a lot of help for this, and my, bless you all, many thanks for all of that. If you're interested in any more in-depth follow-up, please contact us. And if you want to have any conversations about these projects, I didn't, in the Belize projects and some of the ones I talked about, I didn't go into the data collection part because just I didn't want to spend as much time there. And if you are an organization or other entity and you're interested in collaborating with the center, please let us know, because we are very collaborative, and we work with you in developing methodologies and approaches for addressing particular aims. And finally, I hope that this introductory brown bag has given you some idea of what we do and our approach. And there will be more webinars to come where we may focus on, maybe we'll have one on social norms and the way we address social norms, which would actually be a very good one to do. And so look for those in the future. And again, thank you all for participating, and thank you and bless you, Hina, for.
Of course, my pleasure. So everyone, colleagues and friends, this concludes our Brown Bag webinar. I want to thank all of you for spending this time with us. We really appreciate it. Thank you to my colleagues, Dr. Kerrigan, Edberg, and Bingenheimer, and a special thanks to Rosie, Michelle, and Dominique, as Mark mentioned as well. Please follow the center on Twitter and visit our website to learn more about us and to stay connected. I believe one of my colleagues has entered both URLs in the chat field. And very importantly, during this unsettling time, take care of yourselves and stay safe, everyone, and goodbye for now. Thank you so much.